Hello, welcome to BEH 107, Mental Health Disorders. Today we're going to be discussing anxiety disorders and OCD. So what are anxiety disorders? Anxiety disorders include disorders that share features of excessive fear and anxiety and related behavioral disturbances. Fear is the emotional response to real or perceived imminent threat, whereas anxiety is anticipation of a future threat. So, to give you an example, fear is the fact that someone is coming at you with a knife. Anxiety is the feeling that somewhere around the corner there is someone who might be there to threaten you. So fear is real, anxiety is more in our mind about a potential threat. These two states often overlap, but they also differ, with fear more often associated with surges of autonomic arousal necessary for our fight or flight, thoughts of immediate danger and escape behaviors. So if we think about evolutionary biology, we can go back to 100,000 years ago when our ancestors were living in caves and there was always the threat of predators and the idea that they had two choices. They could run and get out of the way, or they could fight the predator and defeat them and then have dinner for a few weeks. So the thought process evolutionarily is that today we still have these same biologic responses, even though we're not often in the same scenarios where we're dealing with a woolly mammoth coming after us. So in this regard, our bodies have the same behavioral and biological responses to what our ancestors experienced 100,000 years ago. Anxiety is more often associated with muscle tension and vigilance in preparation for future danger and cautious or avoidant behaviors. So you hear a lot about how when people who served in the military come home from war, they have a hard time adjusting. And part of this comes down to the fact that they've been living in a very dangerous environment for a long time where they've had to be vigilant. And now they come home and they're living in the suburbs or in the countryside, and when a car backfires, their mind might tell them, oh, that's a car backfiring, but their body is telling them that it could potentially be an IED, a gun, any number of things. So there's this disconnect between what we cognitively understand and what our bodies are getting ready to deal with. So anxiety comes from this preparation inside of our bodies to deal with an imminent threat. But it's more of a potential threat because it's more anxiety than an actual fear. Avoidance and panic. So sometimes the level of fear or anxiety is reduced by what we call pervasive avoidance behaviors. And that means that we just avoid certain things. We avoid being in places that make us uncomfortable. So if we don't like crowds, we tend to stay away from crowded areas. Panic attacks feature prominently within the anxiety disorders as a particular type of fear response. And panic attacks are not limited exclusively to anxiety disorders, but rather can be seen in other mental disorders as well. And we're going to talk a lot more about this in detail as we move through this presentation. So we're going to be looking at 8 specific anxiety disorders: separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder or social phobia, panic disorder or panic attack, agoraphobia, generalized anxiety disorder, substance or medication-induced anxiety disorders. We're going to start off with separation anxiety disorder. And what we have to keep in mind is, for anyone who has children or has spent time with children, when they're little, 2, 3 years old, and mommy or daddy is leaving, the kid freaks out. Well, that is age appropriate. Now, let's go forward to when they're 12 or 13. If mom or dad are leaving and the kid freaks out, that is not normal. And this is where we get into separation anxiety disorder. An individual with this disorder displays anxiety and fear atypical, meaning not typical for his or her age and developmental level, over separation from people and places to which he or she has a strong attachment. So it has to be atypical or not typical for his or her age. There's no specified age of onset. It could happen when they're 9 or 10, 12 or 13, somewhere in their early teens. It can happen when somebody's an adult. Separation anxiety can develop into other disorders, including panic disorder, major depressive disorder, and agoraphobia, which we will also be discussing. It can persist in individuals under 18 for at least 4 weeks and adults for 6 months or more. So when we see separation anxiety disorder, this can be something that is significant and impacts a person's functionality in life because they just are afraid of being separated from someone. Then we move into selective mutism. And for anyone who's ever seen the television show Big Bang Theory, in the first 2-3 seasons, there was a character named Raj who had selective mutism in that he could not speak in front of women. And eventually he did get over that. But it is typically a childhood disorder typified by the inability to speak in certain circumstances. Specifically, it is a consistent failure to speak in certain social situations where there is a natural expectation of speaking, such as at school. And it is often recognized when the child begins school. Selective mutism must be in evidence for more than the time span of 1 month, and it will be determined to have a detrimental impact on school or work. This is not a child being shy. This is a child who literally cannot speak when they are in school. They just physically are unable to utter a word. They're literally unable to get anything out because their vocal cords, their lungs, everything seizes up in a physiological way. So it's a lot of anxiety going on. Then we have specific phobias. And many of us have specific phobias that involve having a persistent fear of an object, place, or situation that is disproportionate to the threat or danger posed by the object of the fear. The person who has the phobia will go to great lengths to avoid the object of the fear and experience great distress if it is encountered. So, one of the most common fears, snakes, spiders, cockroaches. Most of us are much bigger than a spider, and yet we will run screaming from a room and have somebody else come in and kill it or move it out of the way or toss it out the window because we are so phobic we cannot even be in the same room with it. However, these irrational fears and reactions must result in interference with social and work life. So we can have a phobia, but unless it interferes with our lives, it's not a big deal. There are 5 subtypes of specific phobias. Animal, meaning snakes, spiders. Then we have the natural environment. Some people just can't deal with being in the woods. They can't deal with other things that occur in the natural environment. Then we have blood, injection, or injury phobias. Lots of people have phobias about needles, and they will absolutely go hysterical if they have to get an injection. Situational phobias, like being in enclosed spaces, like an elevator, and then assorted other phobias. Some people have phobias about their food touching on the plate. And again, doesn't mean necessarily that somebody has a mental health disorder. unless it interferes with their social or work life. Social phobia, which involves the fear of social situations, is a separate disorder. It is an anxiety disorder involving discomfort around social interaction and concern about being embarrassed and judged by others. And again, there are those of us who are shy, but social phobia is one step beyond. It's not just about being shy, it's about the fear that people are judging you. And it's that fear that people are talking about you and you feel embarrassed and they are looking at you with all kinds of judgment. This discomfort will be experienced as fear and anxiety and will be accompanied by, again, the autonomic arousal, which includes diaphoresis, which means sweating to an unusual degree, apnea, which is the suspension of external breathing, which means you're hyperventilating, you're breathing internally fast, and you're not getting a lot of oxygen, so you're getting lightheaded. Then there's the tremors in your hands, tachycardia, which means an abnormally rapid heart rate, and nausea. It can range in severity to a discomfort, which can be circumvented or adapted to a virtually disabling fear with infiltration into multiple areas of your life. The prevalence of social anxiety disorder is considered to be relatively high at 7% of the general population. The onset usually begins in the early teens, and a major risk factor is obesity as a teenager. And again, teenagers are not always the nicest people when it comes to making fun of each other, and consequently, when we get back into that idea of being judged and being made to feel embarrassed about yourself, teenagers are pretty good at making people feel bad about themselves. So this will just be a major way of inducing this kind of disorder in somebody who may feel already bad about how they look. Then we have panic disorder or panic attack. Two different concepts. You can have a panic attack, but not panic disorder. But if you have panic disorder, you always have panic attacks. So according to the DSM-5, the most prominent diagnostic criterion for panic disorder is recurrent, unexpected panic attacks. Because panic attacks are unexpected, they are impossible to predict, and the patient usually feels like they come out of the blue. This surge of fear can occur during a time of existing anxiety, but can also begin during a calm state, such as while relaxing, sleeping, or while engaging in enjoyable activity. The DSM-5 describes a panic attack as an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes. Oftentimes, people will feel like they're having a heart attack or a stroke because it comes on so quickly. And usually what happens is people will take themselves to an emergency room. The doctors will go through all the biology of the person. They'll check for EKGs, they might check the brain scan, they might do all kinds of neurological and cardiac testing, and then they start talking to the person about what's going on in their social lives or in their personal lives. And they find out that the person may have a particular situation going on at work or at home that has brought about this panic attack. The panic attack might be a one-time thing, but for some people, these panic attacks become a regular feature in their life. Not necessarily meaning that they come on a regular basis every couple weeks, but every 6 months, because this is how their body explodes in stress. And people become panicked about having a panic disorder. And this is this snake eating its own tail. You become worried about having a panic attack, and this leads to having a panic disorder. The prevalence of a panic disorder is between 2 and 3% for adults and adolescents. Some of the risk factors associated with panic disorders or panic attacks include temperament, and this is well documented in terms of people who experience anxiety or have a history of being fearful are at an increased risk of developing a panic disorder. You know, a lot of people out there, they just have a hard time developing coping skills, and as a consequence, their body erupts in a panic attack because the coping skills are not in place to manage the day-to-day stressors. Another risk factor includes childhood physical and sexual abuse. There are some genetic and inherited connections because 30 to 40% of twins share panic disorders. And individuals whose parents experience depression, anxiety, or bipolar disorder are at an increased risk of developing panic disorder. So moving on to agoraphobia. Now, for some of you who may have seen agoraphobia presented in a movie or a television show, they will often show it as somebody who is afraid to leave their house. That's not technically true. That's an extremely extreme version of what agoraphobia can become. But agoraphobics are most commonly known as the people who have a fear of public places. It is an anxiety disorder involving a persistent fear of certain environments, often either due to their crowdedness or their openness, disproportionate to the threat or danger posed by the environment. So somebody may not like crowds, and being in a crowded area might make their anxiety skyrocket. Conversely, somebody who does not like to be alone might be freaked out by being in a house alone for a weekend, and they will go sit at the mall just so that they're not alone. This disorder typically develops in late adolescence or early childhood and is more common in women. Risk factors include stressful life events, poor health, and lower education, lower income, and biological or genetic factors. Then we're going to move on to generalized anxiety disorder. People with generalized anxiety disorder find themselves extremely worried about all sorts of things, even when they have little or no reason to worry. They basically manufacture things to worry about. They may be anxious just trying to get through an average day, always believing that something's going to go wrong. Surveys of the general population suggest that during a person's lifetime, somewhere between 4 to 6% of people will experience generalized anxiety. So, in terms of the numbers, about 1 in 20. Women seem to be more susceptible to generalized anxiety disorder than men, occurring approximately twice as frequently in females. The common age range of the symptoms for generalized anxiety appear 45 to 59 years of age, with a decline in diagnosis after age 60. So, you get to age 60, you're like, forget about it. I'm not going to worry about anything anymore. But, and again, you have to think about a woman who's in her mid-40s to late 50s, oftentimes has, adolescent or young adult children, her husband older. There is a lot to worry about. And, it becomes a habit to worry about things. Symptoms of generalized anxiety disorder must occur for the majority of days over a 6-month time span. Chronic, constant, and often unsubstantiated worry, plus 3 of the following symptoms: muscle tension, gastrointestinal discomfort or diarrhea, cha-cha-cha, irritability, fatigue, edginess, restlessness, and sleep difficulties. Now, for many women, this happens every month for at least 3 or 4 days, but keeping in mind that it has to be the majority of days over a 6-month time span. Then we hit substance or medication-induced anxiety disorder. And this is severe anxiety or panic which is caused by alcohol, drugs, or medications. And it is most common in individuals who are abusing alcohol or other drugs. The substance may induce psychotic symptoms during intoxication, otherwise when the person is using the drugs, or during withdrawal, when the person stops using the drugs. So, think about it from the perspective of the medication can make you anxious. So something that has speed in it, like cocaine, methamphetamines, that makes you paranoid and anxious. When you are withdrawing from a substance, you are oftentimes also very anxious. Your body has a lot of the muscle tension, gastrointestinal distress that we've talked about with anxiety disorders. But also for people who are unwillingly coming off the medication, they don't have the drugs, they can't get the drugs, they don't have the money for drugs, they are also going through extreme anxiety. So this is not a classic anxiety disorder in the sense that the person has a neurobiological disorder or a genetic component. Basically, this is when somebody has a substance abuse issue that is manifesting an anxiety response. So how do we manage anxiety disorders? First, there's psychotherapy. And there's two types of psychotherapy that we use on a regular basis. First, it's cognitive psychotherapy, which helps patients see how automatic thoughts and false beliefs lead to exaggerated emotional responses, such as anxiety. So we have to think about how we think. Why do we think certain things? And oftentimes it's very hard when we are thinking about how we think, our metacognition, to understand. And this processing of information with a therapist helps us get there. The second part is behavioral therapy, which involves a gradual and desensitizing exposure to anxiety-provoking situations and stimuli, and may include relaxation training to moderate the physiological responses to these. So behavioral therapy is more about how we're acting, how we respond to situations, and how we can control our biology. If our heart is racing, if our breathing is rapid and shallow, we start to calm ourselves. We breathe deeply, which will slow our breathing down. We might meditate. We might be able to stretch or do yoga to help our body relax. So there's a lot of behavioral therapy actions that can be taken to help our body with the muscle tension. Both types of therapy are effective for anxiety, and a combination generally yields superior results, especially when used in combination with pharmaceuticals. And speaking of pharmaceuticals, we have our traditional medications. They can be used short-term or long-term, depending on the severity of the symptoms, other medical conditions, and other individual circumstances. The first one is probably the most popular in terms of antidepressants, and this is the selective serotonin reuptake inhibitors, or the SSRIs. This antidepressant relieves symptoms by blocking the reabsorption of serotonin, which leaves more serotonin available, which improves our mood. The second one is similar. It is a serotonin norepinephrine reuptake inhibitor, or SNRI, also an antidepressant, which increases the levels of the neurotransmitters serotonin and norepinephrine by inhibiting the reabsorption into the brain. Then we move on to our anti-anxiety medication, which is benzodiazepines. And you might know these by their names like Xanax, Valium, Ativan. And these medications promote relaxation and reducing muscular tension and other physical symptoms of anxiety. Long-term use may require increased doses to achieve the same effect, which ultimately may lead to problems related to tolerance and dependence. In other words, you can become addicted to benzodiazepines, and doctors are very careful about managing your prescriptions. If there is a concern about you becoming addicted to benzodiazepines. Doctors will oftentimes prescribe tricyclic antidepressants, which block the absorption of the neurotransmitter serotonin and norepinephrine, increasing the levels of these two neurotransmitters in the brains. But these are old school antidepressants and have a variety of side effects. But it also will prevent a person from becoming addicted to the benzodiazepine. So there's some benefits and negatives to benzodiazepines that can be mitigated by these old school antidepressants, but the side effects can be unpleasant, to say the least. Okay, now we're going to move on to obsessive compulsive and related disorders. We're going to be looking at the following 7 issues: obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, which is otherwise known as hair pulling disorder, excoriation disorder, also known as skin picking, substance or medication induced obsessive compulsive and related disorder, and obsessive compulsive and related disorder due to another medical condition. So OCD is an anxiety disorder marked by the reoccurrence of intrusive or disturbing thoughts, impulses, images, or ideas, i.e. obsessions, accompanied by repeated attempts to suppress these thoughts through the performance of certain irrational and ritualistic behaviors or mental acts, i.e. compulsions. The compulsion may represent a strict rule that the patient must apply rigidly in every situation. So, for example, always putting your right shoe on first. The obsessions and compulsions can take up a large part of the patient's day, an hour or longer every day, and usually cause significant emotional distress for the patient and difficulties in his or her relationships with others. So, just kind of put this in context. We're not talking necessarily about minor little rituals. We're talking about significant rituals where a person may have to go through a series of rituals every morning before they leave the house, checking the oven 3 times, checking the iron 3 times, making sure the refrigerator door is closed 3 times. This series of checking and checking and checking makes the person ultimately feel better. The ritual may not make any sense to the person who observes this person, but ultimately what it does is it reduces their anxiety. About 2.3% of the population of the United States is diagnosed with this condition, and the typical age of onset is late adolescence to young adulthood, with slightly more women than men being diagnosed with OCD. Now, for those of you who have heard of obsessive compulsive personality disorder, I want to make sure you understand it is not the same thing as OCD. OCD is characterized by the presence of obsessions and compulsions to relieve the anxiety. Obsessive compulsive personality disorder is a lifelong pattern of insistence on control, orderliness, and perfection that begins no later than the early adult years. So it's more about controlling one's environment than managing one's anxiety. It is possible, however, for a person to develop both disorders. People with OCD experience their disturbing thoughts and images as intrusive and troublesome, but they recognize that their thoughts are products of their own minds. They know that their obsessions are not necessarily real, or they are exaggerated in their own minds. The most common types of obsessions in persons with OCD in Western countries are, number 1, the fear of contamination. So you would often see people who are obsessed with germs, and their compulsion is to wash their hands. Number 2, doubts And in this case, their obsession is they're worried about whether they've forgotten to do something. So consequently, they will spend an hour or so checking to make sure everything's unplugged, making sure everything's turned off. Number 3, an intense need to have or put things in a particular order. So they will obsess on things being in a particular order. Their compulsion is to make sure that everything is color-coded or put from, largest to smallest, because again, that manages their anxiety. Aggressive or frightening impulses. We all have that moment when we're holding a baby and it won't stop crying, and we have that, I'm going to put the baby in the oven and see what happens. No. Most of us don't have that impulse. But when you have OCD, that's the kind of impulse you have. So the compulsion is then to do something that will prevent you from having those horrible thoughts. And you'll do something like make sure the fringe on your carpet is completely lined up, because that'll make you feel better. And reoccurrent sexual thoughts or images. It is important to understand that patients diagnosed with OCD do not perform their compulsions for pleasure or satisfaction. A compulsive behavior becomes linked to an obsessive thought because the behavior lowers the level of anxiety produced by the obsession. So, the obsessive thought kind of takes over your brain, and then the compulsion helps that thought gets pushed away until you don't focus on that any longer. The most common compulsions in Western countries are washing, cleaning, counting, hoarding, checking, putting objects in certain orders, repeatedly confessing or asking others for assurance, repeated actions like touching every step with your finger as you go up or down steps, making lists. And I'm not talking just a to-do list, but a list of, every baseball game you've ever been to or every concert you've ever seen, lists that really are irrelevant. OCD is presently classified as a form of anxiety disorder, but current studies indicate that it results from a combination of psychological, neurobiological, genetic, and environmental causes. Some researchers have noted that OCD is more common in patients who have suffered a head trauma. Recent studies using a positron emission tomography or a PET scan indicate that OCD patients have patterns of brain activity that differ from those of people without the mental illness or with some other mental illness. Other studies using an MRI found that patients diagnosed with OCD have significantly less white matter in their brains than did normal control subjects. Large epidemiological studies have found a connection between streptococcal infections in childhood and the abrupt onset or worsening of OCD symptoms. The general nature of OCD seems to run in families rather than the specific symptoms. So a parent can have OCD that focuses in on hand washing and germ phobia, while their child may have a OCD related to checking. So it doesn't have to have the same parameters, but the OCD is there. Body dysmorphic disorder is a condition marked by excessive preoccupation with an imaginary or minor defect in a facial feature or localized part of the body. The diagnostic criteria specify that the condition must be sufficiently severe to cause a decline in the patient's social, occupational, or educational functioning. Body dysmorphic disorder can be differentiated from the distorted body image, which is a defining feature of eating disorders, in that distorted body image involves a preoccupation with overall body mass, whereas body dysmorphic disorder involves focusing on a specific body part or feature. People with body dysmorphic disorder will undergo unneeded cosmetic surgery, dental procedures, or dermatological procedures to correct a perceived flaw, but are typically not satisfied with the results, as this is an internal perceptual problem. The typical age of onset of BDD is ages 12 to 13, with the average age being 16 to 17. So on the right-hand side, you're going to see two pictures, and this is one of the most famous cases of body dysmorphic disorder, and this is Michael Jackson, the pop star who died several years ago. On the top is his album cover for Off the Wall, which was late 1970s, early 1980s, and he, quite frankly, looks adorable. And below is a picture of him from the early aughts, during one of the child abuse criminal mugshots that were taken, and you can see a drastic difference in how he looks. He had major surgery done to his nose, his lips, and his chin, and obviously he's had his skin lightened, and there's of course some drastic changes going on here in his face. The issue that therapists or psychologists have written about is that he was physically and emotionally abused by his father, who he looks a lot like. And the theory is that he engaged in a lot of this plastic surgery to avoid looking like his father. And his body dysmorphic disorder was in part, traced to this abuse. And of course, having all the money that he had gave him the opportunity to get all these plastic surgeries. The incidence of body dysmorphic disorder in the United States is 2.5% for men and 2.2% for women. Risk factors include sexual trauma, child abuse, bullying by peers, and a serotonin insufficiency or imbalance. Then we move on to hoarding. It is a psychiatric condition that produces symptoms such as the compulsive urge to acquire unusually large amounts of possessions and an inability to voluntarily get rid of those possessions, even when they have no practical usefulness or monetary value. They experience feelings of anxiety or mental anguish whenever those possessions get thrown away. Most affected individuals accumulate things with limited or no real-world value, such as books, old magazines or newspapers, self-made notes, outdated clothing, or old mail. Specifically, junk mail often gets saved. The collected items typically produce enough clutter to limit or prevent the practical use of that space, making it dysfunctional. And in some cases, the collected material also produces an active, ongoing danger in the form of such things as fire hazards or hygiene hazards. And again, these are issues that when you examine the issue, we all have clutter. Most of us have clutter, but it's not dysfunctional in the sense that we can move around our homes, we can move around and utilize our space. These folks have no utilization left in their homes. So here are a couple pictures of space that is no longer functional. In order to qualify for a hoarding disorder diagnosis, affected individuals must experience a disruption in important aspects of their lives, work, home life, social interaction, as a direct result of their hoarding behaviors. Hoarders will oftentimes not allow anyone into their home for months or years because they understand that their homes are not appropriate for the public to see, or they're afraid that somebody will report them. Hoarders commonly give certain rationales or justification for their behavior. They're afraid they might need something in the future, or they have an emotional attachment to the items. They see it as, oh, well, I bought this with my friend and we're not friends anymore, so I want to keep it because it reminds me of this person, and it reminds them of memories. They identify with items. So oftentimes they might go trash picking and they'll find something and they'll pick it up and they'll bring it home with them, and they say, well, somebody threw this out because they felt it was trash, and I feel like people think I'm trash, so I'm going to self-identify with it, and this is, equivalent to me. Other people have aesthetic preferences. There are people who have collected so much of a certain thing over the years that there's literally no space in their home. So somebody who collects, for example, dolls, they may have 5,000 dolls in their house and there's nowhere to walk. Other people collect books or newspapers, anything that they feel has value to them. Or they feel a sense of responsibility to protect the item from being disrespected. If there was something that their mother brought that has, no monetary value but is important to them, it's their mother's furniture. They want to keep it. They want to protect it. It has meaning to them. So, for these people, yes, they're living in squalor oftentimes, but everything in that house has some type of meaning to them, even if it is completely not something we as people who are not hoarders can understand. The current population estimate is approximately 2 to 6%. We can't even really truly get a good understanding of this because so many people are behind closed doors. And it's not clear that they're hoarders until they die or a wellness check is done. On the right-hand side, you'll see a picture. It's black and white. It's from the 20s. And it's two brothers who lived on Fifth Avenue in New York City. Their names are Homer and Langley. They were very wealthy, and they were hoarders to the extent that their apartment became so cluttered that they both died inside of their apartment. The only way they could get around were these small little tunnels that they crawled through. One of the brothers was blind and he got stuck in a tunnel and died, and then the other brother, he also got crushed under clutter. So it became one of the big stories of that era. Gender prevalence is unclear. The average age is 50, although the age of onset is often prior to age 20. Functional impairment and clutter get worse as you get older, and there is support for both genetic and environmental factors. One of the big issues is decision-making deficits. There is indecisiveness, and one of the big activities is called churning. They move things around without actually getting rid of anything. So therapists, when they try and work with people who are hoarders, they will give them a basket of stuff and say, okay, I want you to go through this and I want you to create, 5 things that you're going to throw away. And the person will literally go through everything and reorganize it and not throw anything away. Moving on to trichotillomania, otherwise known as hair pulling disorder. This involves a recurrent, irresistible urge to pull out hair from your scalp, eyebrows, or other areas of your body, despite trying to stop. Hair pulling from the scalp often leaves patchy bald spots, which cause significant distress and can interfere with social or work functioning. People with trichotillomania may go to great lengths to disguise the hair loss. So they'll wear wigs, they'll comb over, they'll do all kinds of stuff. For some people, trichotillomania may be mild and generally manageable. For others, the compulsive urge to pull hair is overwhelming. Some people go for the eyebrows. Some people go for their hair on their head. Other people go for hair on their arms or legs. So it's a way to manage their stress. And again, some people might eat candy as a way of managing their stress. These people are pulling hair out of their heads. Risk factors demonstrate that research is being conducted on the abnormalities in the brain chemicals serotonin and dopamine and its role in trichotillomania. There's also family history. Usually begins around age 12 and often becomes a lifelong chronic condition. And the individuals use it as a way to manage their stress, anxiety, tension, loneliness, fatigue, or frustration. In the same way that you see a baby when they're tired, they're rubbing their eyes, sometimes scratching their face, not meaning to hurt themselves. Well, this is what these individuals are doing. This is how they're managing their stress. Moving on to excoriation or skin picking disorder. About 1.4% of people have this disorder, with the vast majority being female. And you oftentimes see it with fingernails. People will pick the skin around the nails, and it's angry looking sores all over there. Also, during puberty with acne, people will pick the acne pimples until they're sore and bleeding. And it usually begins during puberty because of acne. The face, the arms, and hands often are the go-to areas for pickers, but the DSM-5 does also note that picking can occur anywhere on the body. The targets for skin pickers include healthy skin, minor imperfections, pimples, calluses, old pick scabs, which can be picked at with fingernails or even tools like tweezers or pins. Picking can occur in short spurts throughout the day or for prolonged sessions. Some examine, play with, mouth, or swallow the skin. I know it sounds disgusting, but people are doing this in an almost unconscious way. Some of the risk factors: some people engage in self-disfigurement to reduce attractiveness due to psychosexual conflicts. There is a psychodynamic explanation that skin excoriation represents repressed rage of children against authoritarian parents. It is a maladaptive coping mechanism for stress or anxiety in individuals with impaired coping skills. Dopamine is felt to be involved in skin picking, although there have as yet been no studies of brain imaging or function. Use of drugs that enhance dopamine levels or effect, such as cocaine or methamphetamine, can cause intense skin picking, while dopamine antagonists will reduce skin picking. Substance or medication-induced obsessive-compulsive and related disorders appear in association with intoxication or discontinuation or withdrawal states. Symptoms may also appear with modification or change in use of medication or substance, including at the time of initiation or use of the medication or substance. Withdrawal from the following classes of substances can be associated with this disorder, including alcohol, cocaine, sedatives, hypnotics, and anxiolytics. Medications reported to induce obsessive-compulsive symptoms include, among others, anesthetics and analgesics, bronchodilators, anticholinergics, insulin, thyroid preparations, oral contraceptives, antihistamines, anti-Parkinson medications, corticosteroids, antihypertensive and cardiovascular medications, anticonvulsants, lithium carbonate, antipsychotics, and antidepressants. So pretty much almost everything most of us take. They're symptoms. They don't necessarily mean you're going to develop full-fledged obsessive-compulsive disorder. It may also be caused by heavy metals and toxins such as paint, carbon monoxide, gasoline, and insecticides. And you can also develop an OCD or a related disorder from a medical condition. So, for example, children with a OCD should be tested for infections to rule out pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, or PANDAS. PANDAS may lead to a sudden onset of obsessions, compulsions, and/or tics in a subset of children. Obsessive-compulsive symptoms have also been associated with Group A streptococcal infections such as Sydenham's chorea, which is also known as acute rheumatic fever. So how do we treat OCD disorders? It is a combination of medications and psychotherapy. So cognitive behavior therapy, as we discussed before, that works well, very well with OCD. It teaches the patient different ways of thinking, behaving, and coping with situations that trigger obsessive thoughts and compulsive behaviors. The type of CBT that therapists have found most effective for treating OCD is called exposure and response prevention, or ERP. The term exposure in ERP refers to the practice of facing the repetitive thoughts, images, and urges that cause the severe anxiety associated with OCD. So if you have an obsession on germs, the exposure protocol might be to have you clean your sink with a toothbrush and then have you rinse the toothbrush, put toothpaste on the toothbrush, and then brush your teeth. This would send most people into spasms of, oh my God, that's disgusting, but ultimately most germs are not going to kill you. And it is a way of exposing you to the worst possible scenario and proving that you're not going to die from a few germs in your sink. Other treatments include antidepressants such as Zoloft, Paxil, Prozac, and electroconvulsive therapy, which we've talked about in other presentations. So here are some of the citations that I've used to put together this presentation. If you have any questions, please feel free to text or email me. Otherwise, I hope you have a wonderful day, and I will talk to you later.